fit into the screen. All right, good morning, everyone. How are you? Don't answer because we're recording. But for those of you who don't know me, I am Brian, and I am adjunct faculty member for the spring semester, and I also serve as a tutor. So thanks for joining me today. What we're going to start off with is what Stacy said, is with the medication component. And I don't know if you've seen this yet or not, but on your blackboard you have the list of medications that you're responsible for knowing and the grid by classifications of the medications that you will need to know for your dosage and Pharm test coming up this week. Okay, so before I begin, I just want to tell you a little bit of how I present. What I want you to always remember when you're studying your medications, I want you to be a nurse, correct? So when it comes to nurse, what does exactly that mean? So when you're studying the nurse, and you need to know the name of your medication, and that means your generic and trade name for that medication. Now, just to let you know, that usually on your examination, both names are provided. So both generic and trade are provided, just so you get used to seeing those names together. Okay? U stands for, what is this medication used for? So when you're studying, please make sure you have a general outline of why that medication is used. And this is pretty much how I'm going to present to you today in this review. R is, what are the responsibilities of the nurse? Now, you know in nursing school, when you had medication of the week in level 1, Yolanda gave you that grid. And in the far right corner of that grid, it said, oh, your nursing considerations or nursing indications. That means, what is your nursing care for that medication? So we definitely need to know that. S is, are there any side or adverse effects of that medication that we need to know? And finally, E is there any education that you need to provide your patient? So these are what we need to know for each medication. All the rest of that is kind of good to know, but this is the core principles of when you're studying your medication for the medication examination. Okay, so let's apply being a nurse with studying for medication. And the first classification of medication that I want to discuss with you is the cardiac medications, because that's usually the hardest for most students. But we're going to make it very easy for you today so that we can use and break down a massive topic down into digestible chunks. So all I want you to do for cardiac medications is always remember A, B, C, D. Those are your cardiac medications. We know we're going to have ACE inhibitors, beta blockers, calcium channel blockers, and D, we use diuretics, but I'm going to do diuretics separately. We're going to say for digoxin, because those are going to be my main cardiac medications. Okay? So before I talk about the different classes of these medications, I always want to say to you, when it comes to your nursing care, let's talk about what we do the same for all of them before we talk about how each one of them differs, okay? So it doesn't matter if I'm using an ACE inhibitor, a beta blocker, a calcium channel blocker, or digoxin. What am I going to do as a nurse for all cardiac medications? And you always know the very first thing for all of them is I'm always going to check pulse and blood pressure prior to giving those medications. medications, because you know if the blood pressure is too low or hypotension, you most likely will have to hold that medication. Okay? So always get a pulse and blood pressure. That's a given if it's a cardiac med. The next thing is when I give the medication, it doesn't matter which class I'm given. If it's a cardiac medications, the majority of these are used to lower blood pressure. So that means the side effect of these medications is your patient will be at risk for orthostatic hypotension. And you know that's very important in nursing because everything's safety, safety, safety. Meaning you have to tell your patient to change positions slowly, dangle their legs at the bedside before standing up. Because if they do have orthostatic hypotension and they get up too quickly, the blood pressure drops quickly, and they end up falling on the floor, hitting their head, and we don't know what happens from that point on, okay? So change positions slowly for all of them because we're tinkering with blood pressure. Next thing we want to do for all of them is we know you need to get in the habit of monitoring potassium, okay? Now we know potassium is our cardiac electrolytes. For those who love sodium, fine. But just know potassium will kill your patient the quickest, and it is your cardiac electrolyte. So we need to make sure our potassium is in normal range, and you already know that that's 3.5 to 5. Okay, so we need to know what is our cardiac status or electrolyte before we give a cardiac medication. That's standard. Next thing we want to do for all cardiac medications is we always want to monitor kidney function. And when I mean kidney function, I want to know BUN and creatinine. And the question always is, well, which one is which laboratory value, BUN or creatinine, is indicative of kidney function? And of course, we always like creatinine first, the best, okay? Because this tells us, are the kidneys functioning or not? And you know we have to have proper kidney function for these medications to be excreted. And if there's a problem, then we know the medication may be problematic in the body. So all I'm telling you is please do kidney function, BUN and creatinine, and of course your input and output. And which one means kidneys, input or output? We know that's O for output. We're always monitoring kidney function again. So just a quick recap, give me a pulse, blood pressure, check potassium level and kidney function with a BUN creatinine and I&O, and protect against orthostatic hypotension. That is your standard nursing care for all cardiac medications. Oh, isn't this fun? All right, now that we have done our standard nursing care for all, let's talk about what's different. And that's where we go by class of medication. And you know, Brian, who is me, said A, B, C, D. So the very first one we're starting with immediately are our ACE inhibitors, correct? So the very first thing, what is different when it comes to studying this class? You already know. I'm going to give you a big hint, all right? Everything you need to know begins with the letter A. But before I explain that, we need to understand, remember being a nurse, the very first thing of nurse that I ought to explain to you is the name. And you know the name will contain or end with pril. So we have the month of April, so you can remember that. ACE inhibitor ends in pril. lisinopril, captopril, or any other pril on your list that hopefully you have seen on Blackboard, all right? Now, the next thing in the mnemonic nurse is, what are ACE inhibitors used for? Well, let me break this down for you, all right? In a normal person, you know that blood pressure, pulse, and fluid and electrolyte status is always controlled by the RAS system. And what does that mean? I don't know. All I know is RAS means that renin, angiotensin, and aldosterone system is what controls your blood pressure. So, how does this medication work? We know renin is stimulated by the kidneys, and that converts into angiotensin 1. We have a converting enzyme known as angiotensin converting enzyme that will then turn into angiotensin 2. Now, do you have to remember any of this? No, but let's make it simple. All I am doing with an ACE inhibitor is I want to inhibit or stop. So what this does is just blocks that enzyme so angiotensin 1 cannot turn into angiotensin 2. That's it. Now, why do we not want angiotensin 2? Because angiotensin 2 is a powerful vasoconstrictor, which means if you're constricting your vessels, you have increasing SVR, and if you remember, that's systemic vascular resistance, and that's the definition of blood pressure. So if we stop that by inhibiting or blocking, then I do not have that angiotensin 2 constricting. Okay, so that is it. All I'm saying is this medication is used for the treatment of hypertension because it stops the conversion into angiotensin 2. Wonderful. I already know. As a nurse, we already talked about, I need a pulse, blood pressure, potassium level, and kidney function, creatinine, and INO. I already know that. So let's talk about what's different, okay? The very first side effect I told you, everything begins with the letter A. First of all, our patient may have an ACE cough. And you already know when you're talking about medication and you're assessing your patient and they're on a cardiac medication, if they have a dry hacking cough that sounds like this, you know it's an ACE inhibitor, okay? That's the side effect, and that has to do with blocking angiotensin 2 in the lungs. I don't care. All I know is ACE cough. But what you need to know is, as a nurse, your patient's going to say to you, this cough is annoying, I can't stand it. Well, you have to educate your patient and say, that's an expected side effect. You must continue your medication as prescribed. Because we know if they stop their medication and it's a cardiac medication, they're going to have rebound hypertension and other cardiac events. So just say, yep, we understand the cough, continue taking as prescribed. All right? The next one has to begin with A, and this is a very dangerous one. We know this is angioedema. And all angioedema begins with the letter A. All that means is it's generalized swelling in the tissues of the body, but you need to understand this is deep tissues. So there's fluid in the deep tissues, and know why that's of concern to me is because I'm concerned about the tissues of the face and neck. Because if you have edema in those tissues, what are they at risk for? And you know that begins with A. They're at risk for a compromised airway. Okay? So angioedema, you need to report this and educate them to report any swelling of the face immediately, because this may compromise airway. So please, ACE, cough, and angioedema. Okay? Moving on, that's ACE inhibitor. Oh, that was easy. This is fun. What comes next in the lineup? And you know that will be B for beta blockers. And you know in your nurse acronym, the very first thing we hit is N for names. And you already know those end in LOL. Okay? So metoprolol, labetalol, propranolol, or whatever lol is on your list. All right, what are beta blockers? Before we talk about with use, we have to understand how this system works in the body to begin with. You know what happens is we have beta 1 receptors and we have beta 2 receptors. And our bodies, as we sit here, is that we have catecholamines known as epinephrine and norepinephrine that bind to beta 1 and beta 2 cells. Well, all I know is norepinephrine and epinephrine, your sympathetic nervous system, increases blood pressure, increases pulse, and bronchodilates, correct? Well, for someone who has hypertension, we don't want to keep causing hypertension. So what we need to do is block the receptor sites from epinephrine and norepinephrine from attaching to them in the first place. So let me just explain this so it's easy for you to remember. Since we're given a beta blocker, very first thing we're going to do is block beta 1. And you have one heart. Okay? So that means you're going to have cardiac symptoms. If I'm blocking epinephrine at beta 1, then I'm going to vasodilate, which lowers blood pressure. And that's what I want. That's why we're doing it. Okay? Beta 2, a beta blocker is going to block epinephrine from binding to beta 2. And where is beta 2? You have 2 lungs. All right? Unfortunately, what that means is your patient on a beta blocker is going to have a respiratory side effect, and that is bronchoconstriction. Okay, so it dilates cardiac, which we want, but it constricts the lungs. So beta 1, beta 2. So all I'm saying is when it comes to respiratory, if it adversely affects beta 2, which you have 2 lungs, there's a type of patient that should not be receiving beta blockers. And you know that's going to be anything respiratory related, because I just told you it causes bronchoconstriction. So you know diseases of the respiratory that will be contraindicated is COPD, which is your chronic obstructive pulmonary disease. They're most likely not a good candidate for beta blockers. So be careful with your COPD. Be careful of asthma, which is COPD, okay? And anyone who has any kind of allergies or anything that will affect the lungs, okay? So guess what? You continue your nursing care, pulse, blood pressure, kidney function, and potassium level, but we talked about what is different. Oh, this is fun. Next, C. And you know that classification of drug is your calcium channel blockers. And on your list, we know when we look at the names of them, they end in, some of them end in ene, I-N-E, correct? Like nipetidine, okay? But then we have verapamil and diltiazem, correct? That doesn't follow that rule, so just make sure that follows, okay? Now, we already know we're taking a pulse, we're taking a blood pressure, monitor for orthostatic hypertension, get kidney function and potassium, done. But what is different? How do calcium channels blockers work? We know calcium channel blockers block calcium. Well, what does calcium do in your body? You know, calcium is your electrolyte that is part of cardiac and skeletal muscle contraction. Well, I want to decrease the contractions if I have high blood pressure, correct? So what these medications do is, since it starts with the letter C, they decrease contractility. And is there ever a time in nursing that you want to decrease contractility? And you know, good examples of that would be someone with atrial fibrillation, correct? Their pulse rate is so high, then we would want to deal with their contractility to try to control that. The other thing is angina. And some of these topics you get in level 2 and level 3, but just remember angina is just chest pain. We stop calcium from contracting, and then we allow the pain to go away because the heart is more controlled at rest, okay? So that's what's different. It decreases contractility. So that means do not ever, 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 ever give this to a patient that has heart failure, known as congestive heart failure. Because if their heart is failing, are you going to give something that decreases contractility? It's already failing. You're going to make it worse. Do not ever, ever give a calcium channel blocker for someone in heart failure. So make a big note that is very contraindicated. Do not give it, okay? And finally, for the calcium channel blocker that's different than all the others is do not consume grapefruit juice, okay? You cannot be on grapefruit juice when you're on a calcium channel blocker, because what happens is grapefruit juice, it suppresses an enzyme required to break down the calcium channel blocker, which means they're going to have too much medication in their body system because they don't have the enzyme to break down that medication. That's what grapefruit juice does. So please, no grapefruit juice, please. Again, take your blood pressure, orthostatic hypertension, potassium, and your kidney function. Done. Moving on is D, and we round out the bottom of our cardiac medications. In D, we know we're going to say that's a cardiac glycoside known as digoxin, correct? And what digoxin do? It's different than all the other medications because it increases contractility. So is there ever a time, cardiac-wise, that you would need to increase contractility? Yes, that would be heart failure. If the heart is failing, I need it to pump more forcefully, so digoxin would be a good medication of choice to increase that force of contraction in a heart that is failing. All right, so don't get confused, because the calcium channel blockers decreased it, and the digoxin increased contractility. They like what? Oh, sorry, you don't like orange? All right, I'll switch to black. All right, I'm back to black. All right, so with the digoxin, remember, it increases contractility, or the force of the beat of the pump of the heart. The problem with digoxin is, you learned this in level 1 and they kept repeating it over and over and over it, is you are at risk for digoxin toxicity, which means we need to monitor blood levels of your digoxin level. However, that's not good enough, because when you assess, you can't look at your patient and say, "Ow, I know what their DEG level is." No, we need our signs and symptoms, correct? First of all, what do you have to do as a nurse that's different before you administer digoxin? You need an apical pulse for 1 full minute, and it needs to be 60 or greater to give that medication. Now, in nursing school, I'm just going to make a general statement with any medication, is when something's wrong. For instance, you took their apical pulse and it is 58. What are you going to do? And you just love, and especially in level 2, you just love to call the physician. No, all right? You must give a nursing action before you fart around on the phone with any physician. So what I need you to always do if something's wrong is to stop and hold, okay? And then if there's a nursing action, such as take vital signs, then you can call your physician. You have to be able to talk about something over the telephone. So stay off the phone and do nursing first. Thank you. All right, so I have an apical pulse that is 58 beats per minute. What are you going to do as a nurse? Stop and hold. It is not 60. And in nursing at school, it's black and white. It has to be 60 or greater to administer it. I don't care if it's 59, okay? If it's out of parameter, stop. All right, good enough. So the next thing is, what are our signs and symptoms of digtoxicity? When it comes to digtoxicity, please remember there's always an early sign and symptom, and there's a late sign and symptom of digtoxicity. Now, earliest sign and symptom, please remember, is nausea and vomiting. And you say, "Brian, all medications you're at risk for nausea or vomiting." Yeah, I know, but it's very important if it's digoxin, because you need to say to yourself, if you have nausea or vomiting, I need to monitor that digoxin level. I need to hold the medication, get a digoxin level, and then carry on from there, okay? A late sign and symptom is, if you remember from level 1, is your visual halos, okay? Your visual halos, some people see green, some people see yellow. When I look at you, you look like an angel because you have a halo around your head, okay? So please remember there is early and late sign and symptoms, so please read carefully. They may want early, they may want late. So please know, nausea, vomiting is early, visual halos is late. Finally, the last thing I want to say about digoxin is, what is causing digtoxicity? And what causes digtoxicity is low potassium, known as hypokalemia. Remember I told you for all cardiac meds you need to check the potassium level? Well, this is even extremely important for digoxin, because I know hypo, which means below 3.5, causes digitoxicity. Okay? All right. Those are your cardiac medications, A through D, made extremely easy. Okay? Now, Stacy, are we waiting to the very, very end to ask for questions?
No, we can ask them.
Okay, so it's after each classification of med, we're asking questions. Does anyone have any questions regarding cardiac meds? I'll be glad to answer any question that you have. If you don't have any questions, Stacy will be up next. No questions?
I have a question.
Hand up. Valencia, is that you?
Yes, it is. Hi, good morning.
How are you?
I'm fine, and you?
Welcome to level 2.
Thank you.
Isn't this fun?
It is. I'm excited.
Oh, good. What's your question?
Yes, sir. So my question is about thrombins. So I just wanted to clarify with antithrombins and what was the other one? Let me see. The difference between antithrombin and thrombin inhibitors.
Well, Stacy will cover those when she gets to the anticoagulants.
Oh, this is specifically for the cardiac?
Yes, just specifically for cardiac. We're going to do each section.
Okay, no, I have no questions. So sorry.
Oh, that's okay. Thank you for chiming in. You were the brave one to want to speak to me. Who else is out there? Wake up. All right. No.
Question about beta blockers.
Hi, Ronnie.
Hi. I loved your tutorials. Amazing.
Oh, well, thank you very much. What's your question?
So I have a question about beta 1 and beta 2.
Yes.
So we only have to worry about respiratory issues with the beta 2s, right?
Well, what it does is it blocks beta 1, which is cardiac. And if I'm blocking cardiac, I get the results I want, which is vasodilation, because it's not getting epinephrine. So thus decreasing blood pressure. That's the effect of a beta blocker, because I'm blocking at beta 1. That's cardiac. Now beta 2 is your lungs, and when I block epinephrine from the beta 2, because I'm using a beta blocker, this causes constriction in the lungs. So that's why I cannot give it to someone with COPD. It's reverse thinking because you're thinking of what epinephrine does, but we're blocking that. Does that make sense?
That makes sense. Thank you.
You're welcome. Okay.
I have another question.
Oh, yeah. What do you want?
So sorry. So are beta blockers selective?
Yes, there are selective types of beta blockers. We also have something called beta receptor 3, but I'm not even going there because your test will never be broken down by the selective and what beta site it attaches to. So
Okay.
We're not going there.
Thank you.
Just know if it ends in lol, do your standard nursing care I talked about, and remember what I talked about, what's different for each one. So concentrate on your nursing. The nurse can't fix where it attaches and how those chemicals, what they do. Some sort of chemist came up with that, but I can do my nursing care. That's priority for these types of tests. All right, thank you very much. And Stacy will continue on. I'll be back.
Somebody else. Is there another question real quick? I thought I heard a hand go up.
Keep going, I'll answer it later.
Oh, I was turning it off. I was going to ask, so if someone is on non-selective beta blocker and let's say have COPD, would we worry about that, or that's kind of more up to the doctor's decision?
Carefully.
Yeah, just use carefully. There are some patients can have that black marker, please.
Yeah.
there are some patients that if someone's going to have a reaction from somebody that has, like, say, asthma or COPD, and they start them on a beta blocker, they have to watch them carefully. But usually after a while, if it doesn't affect them, they're fine. So don't freak out if you have a COPD patient who's on a beta blocker.
Okay.
It obviously means that they've been on it before, it's not affecting them. Okay. All right, so we're going to get into some insulins for you guys. Now, I'm going to warn you right now, I am not as entertaining as Brian. So he's all excitement, and now we're going to kind of just chill a little bit. Okay, but I'll try my hardest to kind of follow. All right, so we're going to get into insulins. So we're going to do Novolog, regular. Wait, where's my little cheat sheet? Let's see, NPH. Make sure you can see all this. Okay, and then put that down just a little bit. And then we're going to say Lantus. Can y'all see the Lantus down there? I think y'all should be able to. Yes, no?
Yes, you can see it.
Okay, sorry about that. Okay, O, P, and D. I'm going to try my hardest to make sure y'all can see all that. If you cannot see all that, somebody just let me know. Okay, so we need to go over the Novolog, the regular, the NPH, and the Lantus. Now, Levemir is pretty similar, and I'll tell you the slightest difference with that. Okay, here's how I want y'all to remember. So all of y'all had Yolanda before. I already know that, okay? Y'all have not had me before. Some of y'all may know about Brian, and everybody should know who Sandra McCreary Marshall is. So that's how I'm going to identify all of these, okay? Novolog onset is going to be 15 minutes, okay? Sorry, I got to get my little sheet stuff. Okay, the peak is going to be between 1 to 2 hours, and duration is going to be 3 to 4, okay? I am Novolog. I am the fastest of the whole group. I am faster than Brian, I am faster than Yolanda, and I am faster than Sandra, okay? But I come in fast to the party, and I leave the party fast, okay? So that's kind of how I'm just going to have y'all remember it, okay? So regular is Yolanda. She thinks she's as fast as I am, but nope, she is not, all right? Because I can run faster than she can. All right, so onset is going to be 30 minutes to 1 hour, okay? Peak is going to be 2 to 4 hours. The books change all the time, so I have to make sure I have cheat sheets. And then the duration is going to be 5 to 7. Okay, so there's Yolanda. She's regular, okay? And then she's going to come to the party after me, but she's going to stay longer at the party. Got it? All right. Now, we have Brian. He thinks he's Novolog. He's not Novolog. He's not even regular. But I will say he's NPH, okay? So that's what I'm going to say that he is. So NPH, onset, 2 to 4 hours. Peak, 4 to 10 hours. And then duration is 10 to 16. So once again, I'm the one that's at the party first. I leave first. Yolanda kind of comes right behind me. Brian likes to make his little entrance. He thinks it's grand, but it's pretty grand. It's not that grand, but he kind of comes in about 2 to 4 hours. He's going to peak at 4 to 10, and he's going to stay at the party anywhere from 10 to 16 hours. Okay? Now we're going to talk about Lantus. So Lantus is going to be, onset is going to be 3 to 4 hours. Okay? There is no peak in your book for Lantus. Okay? And then the duration is going to be up to 24 hours. Okay, well, that's Sandra. Okay, Sandra is always late to the party. She is the last one. All right, so she comes in late. She comes in 3 to 4 hours. She doesn't really peak. She kind of hangs out. So she's going to stay at the party as long as up to 24 hours. Okay, so we've got Novolog, we've got regular, we've got NPH, and we've got Lantus. Now, the only thing I'm going to tell you is there is something called Humalog. For Humalog, the onset, peak, and duration are exactly the same, but they are not the same medication. I need you to understand that. Okay? Now, make sure you mute yourself right now. So just know that if you see an order for Humalog and you go into the med room and you look in the little refrigerator and you grab Novolog, you're like, well, that's the same thing. Well, it's not. So please do not get Novolog and Humalog mixed up. They have the same same onset, peak, and duration. All right. So that's Novolog, that's regular, that's NPH, and that is Lantus. Now, just to tell you, the only thing that's really different on for Levemir, sorry, this is a little bit low. Levemir. Okay. Your book says that Levemir will peak, same thing. I mean, onset will be 3 to 4 hours. Okay. And then your peak will be 3 to 14 hours, which is kind of weird. And then it says the duration says 6 to 24. If we're going to ask you a question, we're not going to get that specific. I mean, it should be pretty obvious whenever we look at these long-term ones. So what my advice to you, and I'm going to keep going on a little bit more on some other insulins, is when you come in to take your Pharm exam, my advice is we're going to hand you a scratch piece of paper. I know how most of y'all think. Go ahead and before you even take your exam, write down your insulins, okay? That way when you get to a question on insulin, because the question is going to be something like, the nurse is administering regular, what is the peak time, which would be if I gave regular at 7, and then my peak time is going to be between 7:30 and 8 a.m., okay? So that's the type of questions we'll be asking you. So a lot of times for you, so you don't panic going, oh crud, it's asking me, it's insulin, oh my gosh, all these numbers in my head. If you wrote it down, it's right there on your scratch piece of paper, and then you're like, okay, now I can breathe. Oh, look, it's 1 to 2 hours, so 1 to 2 hours is between this time and this time. I think that will help you guys out. All right. Any questions on Novolog, regular, NPH, and then the long-acting? Yes. Nisi.
Hey there. Do you mind moving the camera down just a little bit so we could see the Levemir? Thank you.
Yeah. Okay, but can you all see all of it?
No, we can't really see the top. Just a little up, because we have space at the bottom now.
Okay, but can you see Levemir and can you see Novolog?
Yes, now we can.
That's all I care about. Okay,
Thank
good.
you.
I just can't see because my screen is so small. I don't know what it is. Okay, is everybody good? Now, just remember something. When it comes time, if we're going to mix anything over here, we never, ever, ever, ever mix long-acting. You're going to have to shoot your patient twice. I'm sorry about that. Stick them, whatever you want to call them. It just is what it is, okay? But you can mix Novolog and NPH, and you can mix regular and NPH, okay? So let's go ahead real quick and talk about, I always get confused, which one do I drop and which one do I do whatever. So let me go ahead real quick and show you that. So the little acronym, and let me make sure because I always get myself confused, is you have NR to RN. Okay? Now you're like, what the heck is that? All right. So you think about it this way. If I'm going to draw up regular and NPH, I'm going to put the air, this is for air, the air goes into the NPH first, and then I take it out, and then I'm going to go put my air into my regular, okay? But to draw it up, that's that, remember that clear to cloudy, okay? So clear is always a regular, that's clear, I can't spell, and NPH is always cloudy, okay? So to draw it up, I'm going to go regular to NPH. So just something to kind of think about. So if I were to have, it's really big, but I don't care. So this is my syringe. I'm going to pull up so much air, okay, for NPH, and I'm going to go to my NPH, and I'm going to put it in there. So say that's 10 units. Immediately take it out. Then I'm going to grab my regular, put the air into the regular, and then immediately flip it over, and then I'm going to draw up my regular, take it out, and then I'm going to draw up my NPH, okay? If you get a little bit too much of your NPH, you cannot stick it back in there. You're going to have to just go, whoops, I messed up, and it's okay, guys, because we do that. And what y'all gonna do? You're like this. You're all shaking, you're nervous because we're watching it, okay? So if you have to just get rid of it and discard it, that's okay. All right, we've done it before too. I'd rather you give a correct dose than to go, oh, maybe she didn't see, I'll just kind of stick it back in there, because you can't. You cannot be mixing it like that, all right? So I want to make sure that everybody is good on how you're going to draw it up. You're going to go NR to RN, okay? Now that's the same thing when it comes to Novolog and Humalog. So I know it says the R, just remember R is the regular, but it also can cover the Novolog and the Humalog. I just don't want to confuse you and put two N's and you're like, I don't know what the heck you're talking about. Just remember the fast or rapid actings, those are going to be your R's. Okay, so Novolog, you put the air in, you drop your regular or your Novolog and Humalog, and then for air, and then to drop the medication, you're going to go regular or your Novolog and Humalog, and then you're going to draw up your NPH. Okay. Let me go over a couple of more of the insulins. (70-30), and then this is going to be your Novolog. So Novolog, and then I also have a 70-30, which is going to be my regular. And when I say regular, it's a mixture of regular and NPH, or it's a mixture of Novolog and NPH. Okay, so now we've got to decide what's our onset, peak, and duration of these. Here's O. Oh, my thing is going out. O, P, D. All right. So let's start with the fast one. Remember, I'm fast. I'm the fastest. Okay, I'm rapid. Okay, to where regular is fast. So I know it gets confusing. Just rapid is faster than fast. Okay, I am the fastest. I am Novolog. Yolanda is regular. Okay, and we both want to go and have and meet up with Brian. How about that? Okay, so for the Novolog, my onset, remember that's the fast one. That's the rapid one. So that's going to be 15 minutes. Okay, and then for my peak, it's going to be 1 to 4 hours. And then for my duration, it's going to be 18 to 24 hours. Okay, when you got 70-30 with your regular and your NPH, that's Yolanda. She's meeting up with Brian. That's a little bit different. Remember, onset takes a little bit longer. So the onset is 30 minutes. Your peak is going to be 2 to 12 hours. And then your duration is up to 24 hours, which is really weird in my brain because I'm like, how can NPH go all the way up to 24 hours? Because that's not the long acting. But hey, I don't write the book, so can't tell you anything about that. So just remember with this. So again, these are things that you may want to write down because we may ask you a question that may say the nurse is administering 70-30, and we will be specific. We will say 70-30 of either the Novolog or with the regular, and they are administering the medication at 7 a.m. At what time would the peak be? Well, I'm like, well, the peak's going to be anywhere between 1 to 4 hours, so 7. So anywhere between 8 and 12 a.m. is going to be when it's going to peak. Okay. So again, I think just that's how I am. I start to panic when it comes to all these numbers. If I don't already have it written down, it just really helps sometimes just to write it all down before you take your test, and that's dealing with your insulins. Now you can't come in with it pre-written. Okay. You got to wait till you go sit down. We'll give you scratch paper. You have as much scratch paper as you want, and then you can write it down. Okay. Are there any other questions so far on the 70-30? Are we good on that? And are we good about how we're going to draw up, how we're going to put the air in, and how we're going to draw it up?
Not really.
Okay. Is it Nancy Ortiz? Is that how you say your name? I'm sorry. Did you have a question?
Yeah, no, that wasn't me who asked that.
Oh, okay. Sometimes it just kind of pops up later to where I might have missed it. Okay. All right. So everybody's good on this. So that's insulin. oh, okay, there is only one insulin that you can give IV. So don't say it out loud. Don't say it out loud. Just think about it for just a second. Out of Novolog, which is me because I'm the fastest one, and then you got regular, which is Yolanda, and then you got NPH, which is Brian, and then you got the long-acting ones of Lantus and Levemir, which is Sandra. Think, who can be administered IV? There's only one.
Yolanda.
And the answer is, yes, you're right. It's Yolanda. It's the regular. So just to know that if for some reason you ever had to give insulin IV, that is the only one. Okay? So that's how we like to make Yolanda feel special. That's how she's special. Okay? All right, that's insulin. What I want to do is just for a second, because it's on your Pharm letter, is briefly just talk about some oral hypoglycemics. Okay? You've got, I don't have the Pharm memo in front of me, but you have, hang on, you've got like, give me one sec, I want to make sure. You've got glucophage, glyburide, and glipizides. Okay, so they all a little bit differently, but their goal is to make sure that that it brings down the blood sugar. You cannot give oral hypoglycemics to a type 1 diabetic. It's going to do nothing. If their pancreas is not secreting any insulin at all, you're giving them a placebo pill, basically. It's going to do no good for them whatsoever. It's only for type 2 diabetics. Just remember that, okay? So cannot give it to a type 1. All right. So when it comes to those, the glipizide, glyburide, those are kind of similar, but there's something different with glucophage, okay? Now, just hang on just a second. Nobody answered just yet. Before I administer glucophage to a patient, it can actually affect a certain system on that patient. Let's think about that for just a second. And the answer is, anybody want to just throw that out for a second? Does anybody know the answer? What system can glucophage affect?
Renal?
Absolutely. Absolutely. All right. And out of the renal, I've got a BUN and a creatinine. All right. So BUN, if your BUN is high, that just basically says, or the patients, that just basically says that they're dehydrated. Okay. If their creatinine is high, then that says they're just starting to have some renal issues. You can have their creatinine be normal, but their BUN is high. All that's telling me is, hey, my patient is dehydrated. All right. If I don't correct this BUN, then it's going to start to affect my creatinine, because my kidneys can be without fluids for so long and be dehydrated for a little while, but after a while they're going to be like, I am so thirsty. Okay, that's it. I'm going to start to shut down. That's when we're looking at the creatinine. So if I'm going to, especially either start a patient on glucophage or they've been on glucophage, and I'm going to tell you, you guys make sure you know what the word trend is. You've got to look at your trends on your labs. It is so important. If my patient has been on glucophage and their BUN or their creatinine level was a normal, and then I start to go and then I come back a week later and I'm like, oh my gosh, it is starting to spike. Then I need to notify the healthcare provider and say, hey, I noticed that the creatinine trend on my patient has gone from blank to blank. All right, and they're on glucophage. So do you want to maybe, like, do you see that and maybe order something else? You can always ask for what you want, guys. Don't just say, hey, it's hot. What do you want to do about it? I mean, if you don't know what you want, that's okay. But if you know what you want, ask. Okay? So that is the main thing that I want to make sure that you guys know, is that with glucophage, it can affect the renal. All right? So I need to be looking at the creatinine more than anything else. There's one more thing with glucophage. Because of renal, there is something that you cannot allow your patient to be or to have. Does anybody by chance know the answer to that? Because if they were to have this and they take their glucophage, they will go into renal failure.
Contrast.
You got it. It's IV contrast. All right. So you cannot IV contrast. I can't spell. It's not a first for me. Okay. No IV contrast if you're going to give your patient glucophage. There is a time time frame. So you need to find your facility policy, so many hours before, maybe so many hours after. Everybody's a little bit different. But I'm going to tell you something, guys. I guarantee you, if you do not hold that glucophage before they go, have some kind of like abdominal x-ray of some sort, or a CT, I'm sorry, CT, and they say with contrast, you better say, can't. They cannot have that CT today because I already administered their glucophage. That is your job as a nurse to make sure that you are notifying your healthcare provider about that, because they will go into renal failure. And that's sad, guys. You don't want to put your patient in renal failure ever, ever, ever. Okay. All right. So that's all I'm going to talk about when it comes to insulins or hypoglycemic medications. Any questions on that before we move to the next one?
Can you please go over again when you're drawing the air, putting the air in, that part?
Okay, so it's N, R, to R, N. So would you say Nancy what?
Nancy Reagan.
Oh yeah, Nancy Reagan, which y'all probably don't even know who that is. Okay, you're all way too young, but go back to your history books. Okay, to RN, that's what I am. Okay, so this is NPH. This is your regular, or it could be, now I know it says R, but that's anything that's a fast one. That's Novolog, Humalog, or regular. Okay, you're going to put air in this order. Then you're going to draw up the medication in this order. So that's your regular, and that's your NPH.
Okay, so what you're saying is before we draw anything, depending on what levels, like if we need 10 units of one and 5 units of the other, we're going to put 10 units of air into the N and then 5 units into the regular, and then go back to the regular, flip it upside down, and draw out the 5 units of the regular, and then go to the NPH and draw out the 10 units of.
You got it.
Okay.
You got it. So just remember, when you stick your air into the Novolog, the NPH, that's fine. And then you stick your air into the regular, don't take it out. Leave it in and just flip it, because now you're going to draw from there first. So it kind of goes backwards. It goes NR, RN. Do you see kind of how we're flipping that a little bit?
Yes, ma'am. Thank you.
Okay, you're welcome. Another question? Was there, or did that answer somebody's?
Nope, got it. Thank you.
You're welcome. Okay, what's next?
Me.
All right, Brian's next, so it's time for some more humor.
No, please.
Or at least he thinks he's funny.
Oh, my head is cut off. I'm taller than you. All right. I'm back. Well, I've been called many things before, but never an insulin. And all I have to say is that I will be at no party for 16 hours now that I'm well into my 40s. But anyway, moving on. What I want to talk about is you have a lot of medications under the topic of pain. And I want to make this extremely easy and just condense it down to usable steps for when you study and when it's time for you to take your test. Now, from level 1 with all our physical assessment, everything we do to assess pain, we're always using the pain scale. Well, if it's good enough for clinical and it's good enough for the lab, it's good enough for a dosage pharmacology examination. So let's do that. We're always using the pain rating scale, starting from 0 to 10, and in the middle is moderate pain, which is 5. So this is what we're going to use to study. So everyone draw your pain scale, 0 to 10. And the first one we're going to do is say 0, 1, 2, 3. We call this mild pain, right? 4, 5, 6, draw your line, and that's going to be your moderate pain. And then 7, 8, 9, 10-ish, we know is our severe pain. So now that we've created our grid, we're ready to fill this in. So let's start in the category of 0, 1, 2, 3, which is your mild pain category. we know these medications, first of all, will differ in this instance because they all will be PO or by mouth. Some examples that you have that you're required to know is your NSAID medications. And your example of your non-steroidal anti-inflammatory drug will be ibuprofen. Other things that will be used to treat mild pain will be our acetaminophen, which is our Tylenol. Okay. And then we may use aspirin. All fall in your mild pain categories. Now on your list, I believe you have naproxen under, I'm just going to go with ibuprofen, okay? So the very first thing we know, all these medications are going to be PO in their use for mild pain. But how do they differ? And you know the huge differences on these are, where are they toxic? And we must identify where they're toxic so you know when you expect these medications to be ordered. So your NSAID medications, where are they toxic? And we know they're toxic to the GI, known as your gastrointestinal system, okay? They may cause erosions or bleeding in the stomach or intestinal lining. So, for instance, if Mary Jo Buttafuoco, who is your patient, has a history of peptic ulcer disease or anything GI related, you best not be picking ibuprofen because we already know it's toxic to the GI system. Now, acetaminophen, which is your Tylenol, has a different toxicity. And we know it is hepatotoxic. You know hepato means liver. So it's toxic to the liver. So that means you know since level 1 that there is a maximum dose of acetaminophen that we can receive in a 24-hour period. That's so we don't destroy our liver. Our liver is what metabolizes medication. So that's why we have to limit its use. We know the limitation to acetaminophen is 4,000 milligrams in 24 hours, and we know that 4,000 milligrams is 4 grams. They're both the same thing. So 4,000 milligrams in a 24 hours is the maximum dose you can have. And remember that because that will be important when I get to moderate pain. All right, now, finally, with aspirin, if we're using that for the control of mild pain, I know that aspirin is an antiplatelet aggregator. And some of you love to put aspirin with an anticoagulant because it causes bleeding as the side effect, but it is not. It is an antiplatelet aggregator, which simply means that it stops platelets from sticking together. And that's more important when we're not using aspirin for pain, which I'll discuss in 1 minute, okay? But aspirin, the side effect you want to know is you're at risk for bleeding because it stops the platelets from sticking together. So that means if you have an orifice or a hole, you better look at it to see what's coming out of it, because that's how we're monitoring for bleeding, correct? We're looking for blood in stool, we're looking for blood in urine, we're looking through blood through your nose, and you know the term for nosebleed is epistaxis, okay? So please monitor for bleeding. All right, now this is how this will work. Are you ready? Mary Jo Buttafuoco has come to the clinic, and she has a history of alcoholism, and she has cirrhosis of the liver. Well, what does all that mean? All I heard was liver. She complains of mild pain. What does the nurse expect to be ordered for the treatment of mild pain? So you have to say to yourself, she has a history of alcoholism and a liver condition, so I cannot give a medication that affects the liver. So which med on an exam would you eliminate?
Acetaminophen.
Acetaminophen, Tylenol. Good. Now, another way of putting that question is Mary Jo Botafuco, who is your patient, comes to the clinic with peptic ulcer disease. All right, all I know is I heard peptic, which means stomach, and ulcer, which means ulcer. It's bleeding in the GI tract. What do you expect the physician to order? You have to eliminate anything that's GI or bleeding. So in this instance, you expect the physician to order acetaminophen or Tylenol, because that's not GI toxic. So do you see how that works?
Yes.
Isn't that fun? Oh, that's fun. All right, let's move on.
Yeah.
In the middle category of 4, 5, 6, your moderate pain category, we know our medications will be, again, PO, or by mouth. And what we're turning to in the moderate categories are opioids. Okay? And your opioids on your medication list is Vicodin or Norco, okay? And what's not on your list, but a good example that's common, is Percocet. And then not on your list, or it may be on your list, I don't remember, is Tylenol number 3, which is acetaminophen with codeine, okay? Those are all considered your opioid medications. But let me tell you something. Your Vicodin, Norco, Percocet, because it is an opioid, you know we always have a common side effect and we have an emergent side effect. Now listen to my language. Common and emergent. So on a test, I need to students say respiratory depression, respiratory depression. That is not common. That is emergent. I know what is the most common side effect of these PO opioid medications. I know is constipation, okay? But what's emergent is respiratory depression. So that means my nursing care for these medications is I need to take the respiratory rate, okay? And again, in nursing school, if it's below 12 or 10, I don't know what you were told, you need to look it up. But if I'm going to say 10 breaths per minute, because that's what's on your med guide in level 1, you will hold the medication. So don't get on the phone and report it and say they're in respiratory depression. You need to hold the medication when something is wrong, okay? All right. The other thing I want to say, so we know our side effects of common versus emergent. But with Vicodin, Norco, Percocet, or Tylenol number 3, remember these medications are always a fraction, okay? Which means there are 2 ingredients in those medications. The first number in that medication is the opioid. The second number in that medication is acetaminophen. So for instance, let me take Vicodin, Norco, okay? I know the first number, the opioid, it's hydrocodone is the name. And the second number in that dose is acetaminophen. Why is that important to you? Because remember when we were in the mild pain category with acetaminophen, that's hepatotoxic. Remember, if you're giving acetaminophen plus Vicodin or a med from this category, they all contain acetaminophen too, which means you have to add up all those acetaminophen to make sure you're not exceeding 4,000 milligrams in 24 hours. Does that make sense? All of these are containing acetaminophen, except Tylenol number 3 contains acetaminophen and codeine, okay? But they're all fractionated, is what I'm saying, which means they contain acetaminophen. All right, moving on. The final category of pain medications, we know we turn to opioid narcotics for our severe pain. And what's different about this class, we talked about routes, correct? We may have PO, however, we have narcotics or opioids that are transdermal, IM injection, IV push. It's multiple routes for the treatment of severe pain. Our most common ones, of course, is morphine, and I know that's not an approved abbreviation, but I'm using it because I'm running off the board. Morphine and Dilaudid are on your list, correct? Now, because we're giving these many different routes, and usually in strong doses, we again have common side effects because they're opioid narcotics, and we have emergency side effects. What's my common side effect? I'm having problems stooling. So constipation, okay? But my emergent side effect is respiratory depression once again. So don't panic if it's below 10, and don't fart around on the phone. Remember, you're always stopping and holding the medication. Do not give because you'll cause further respiratory depression. Now, when we're talking about narcotics, we know if they have severe respiratory depression and are symptomatic that we do have an antidote for these medications. And it requires no thought at all because you know it's narcotics we're dealing with. So you already know the antidote is Narcan. It has narcotic right in it, all right, Narcan, and we already know the other name for that is naloxone. Now, I have a question for you. Your patient puts on their call bell and says, "Nurse, I know you're from ACC, however, I am in severe pain, but I haven't moved my bowels in 4 days. I have a stool in there the size of a Volkswagen, and I'm unable to pass it." Are you going to give them their pain medication? Always. Because remember, in nursing school, we can get an order for their bowels. The pain is always what the patient says it is. And if we don't give pain medication as prescribed by our healthcare provider, and they're lingering in severe pain, we can throw this whole graph at them. We will never catch up and control their pain. So it's what they say it is, and we always will medicate with our pain medications on time as prescribed, because if we fall behind, we will never catch up. So I don't want to hear it. You don't deny pain medication because they haven't had a bowel movement. Please. Okay? We can get colace, which Stacy will talk about later. That's pain medications using your pain chart 0 through 10. Any questions on the topic of pain medicine? Okay, thank you very much.
I have a question, sorry.
You have a question? All right.
So this may be silly, but say you're coming on shift and you want to calculate the total amount of acetaminophen in the last 24 hours. When does that start? How do you determine the beginning of the 24 hours?
So look at your charting method to see when the 24-hour period begins. Does 24 hours begin with day shift? If at facility it starts at your 7 o'clock a.m., that's when it will begin.
Okay, so it'll be specified per like facility policy probably.
Whatever the start of your 24-hour period is.
Okay.
Some start at night shift at midnight is your 24-hour mark. It just depends where you are, because long-term care is different. But whatever, like you said, it doesn't matter. Just know when it starts so you can calculate your acetaminophen to make sure you don't exceed the 4,000.
Awesome. Thank you.
You're welcome. Thanks for your question. And we have the same name, except yours ends in A.
Okay, let me add something to the question that you just had about that, about the 24-hour. And no, Brian is right. The only thing that here's going to be an example. If you're in clinical with us, and then you're going to say, hey, my patient wants some Tylenol, and we say, okay, well, how much Tylenol have they had in the past 24 hours? That's going to be the 24 hours from right then. So if it's like 11:30 in the morning, you can't go just to 7 a.m. and say, well, they haven't had anything since 7 a.m., so they've had none. I'm like, no. If it's 11:30 a.m., I need from 11:30 a.m. to yesterday at 11:30 a.m. That's how you're going to have to calculate it up. So you may have to go and look back. If it's paper charting, you will have to go and get the chart itself and look back at your MARS from the previous day. So that's how I will let you know in clinical if we're saying, hey, if it contains Tylenol, and you say, can I go and give it? And I'm going to say, how much have they had? You can't say none because there's nothing since 7. Okay, so I just want to make sure with that. Kind of want to add to that. Okay. Did somebody else have a quick question? I'm going to use this one. Are y'all good? Okay, I'm going to take that as y'all are good. All right. So let's go ahead and talk. I'm just going to briefly talk about stool softeners because he was talking about pain. Okay, so there's lots of different kinds of stool softeners / laxatives. Okay, if you're going to give a stool softener, there's a commercial, and this is how I always remember it. A stool softener doesn't necessarily make you go, it helps it go better. I think there's some commercial that's like that. All right, so if I'm going to give a patient a stool softener, some things that will help that stool softener work better is you're going to do a couple things. So if I'm going to give a stool softener, doesn't matter what kind, so I'll just say I'll use Colace. That's just going to be my example. Okay, so if I'm going to give that, I want to have my patient increase their fluid intake. Okay, and you're like, why in the heck would I want to do that? Well, the reason that you want to do it is because when you can increase that fluid intake, because a lot of times if they're like constipated because they've been on a narcotic for a long time, then it gets really hard. So if we're going to give a stool softener and then we can give some fluid, especially water, it helps to soften it so it can go better down the track. Okay, so that's the biggest thing, especially with stool softener. Something else is think about what else would help your patient to have a bowel movement. Well, we want to, if they are able to, we want to increase their mobility, right? Those are a couple things right there that can actually help. Now, the only thing I'm going to tell you with increasing your fluid intake is if you have a patient who is CHF or in their renal failure, you can't walk in there and tell them to drink as much water as they want to. Okay, and because what you're going to do is you're going to make it worse for them, because then if they have CHF and you just told them to drink a whole big jug of water, you know, in the next couple of hours, you're going to put them into fluid overload. All right, so think about patients who have heart failure or patients who have like renal problems, and I mean more like the end stage renal. Okay, so those are some things just to think about. I mean, if the patient can move, great, guys. And it doesn't, when I say increase mobility, if they can ambulate, that's wonderful. Not everybody can, but I'm going to tell you something. If you can get them up from the bed to the chair, that is movement. Okay, that's movement. Anything is better than nothing. So those are some things just to think about. Okay, so that I just wanted to add the little stool softeners with what he was talking about, because especially, and it's really good, guys, if you, before you give a patient any kind of narcotic, always ask them, when's the last time you had a bowel movement? Because if it, you know, and then ask them, what is their regular pattern? I might go every day, but Brian might go once a week. I'm just kind of giving you an example. All right, so if that's his norm, don't freak out when he says, well, it's been 5 days. I mean, I think that's a little weird, but not everybody's different. So know what is their normal pattern, okay? Because the last thing you want to do is create a problem on top of a problem. So you want to always ask them. So that way, like I said, yes, I'm going to go ahead and give them something for pain, because the last thing I want them to do is have their pain be sky high and withhold pain medication just because I'm worried about them not having a bowel movement. I can always get something, I can call the doctor. If the patient says, hey, I'll just let you know that I want to, narcotics always make me constipated, go ahead and ask the doctor for a PRN of a stool softener or something, okay? Ask for what you want and talk to your patient and ask them what works best for them. If they haven't had a bowel movement in a long time, I might ask them, okay, what works for you? Maybe they say, hey, I don't even want a stool softener. If you just get me some prune juice, man, I'm going to go like you never believe. I would rather do something that's not medicine, if at all possible, okay? Maybe it's a bran muffin. So ask them what works best for you that helps you go whenever you've had issues in the past, okay? All right, so that's a stool softener. Anticoagulants, okay, so Brian was talking about aspirin. So aspirin is not an anticoagulant, it's an antiplatelet. So what are you going to assess prior to ever giving aspirin? There's going to be two things. If it's an antiplatelet, well, there's one word for you. You're going to assess their platelets, okay? Something else that you're going to assess is you're going to assess their hemoglobin and their hematocrit. I'm really more about the hemoglobin than I am anything else. Okay, if I go in and I notice that my patient's hemoglobin in one day has dropped from a 10 to an 8, I may want to hold this aspirin and then contact a healthcare provider because that's a significant drop. Are they actively bleeding somewhere? I don't know. I have to figure it out. So any kind of antiplatelets or anticoagulates or anticoagulants, we want to assess for bleeding. Bleeding where? Okay, is it going to be bleeding out of the eyes? Well, gosh, I sure hope not, okay? But bleeding in the gums, bleeding in the stool, bleeding in the urine, okay? So you can always tell your patient, hey, if you ever notice any blood in your stool or urine, let me know. If your gums start to bleed a little bit, let me know about that. But I'm not going to rely on them to tell me. I have to be looking at it as well, okay? So I want to make sure I'm assessing for aspirin. It's going to be platelets, hemoglobin, and hematocrit, okay? So yes, that's definitely something I want to do. Now, when it comes to anticoagulants, that's a little bit different. So with anticoags, all right, they're a little bit different. So examples are Coumadin. No, I'm not going to spell this right, so sorry. Eliquis, I'm guessing. Eliquis, oh, it doesn't matter. Okay, spelling doesn't count today. Xarelto. Okay, and then I think there is something else. Okay, so these are all anticoagulants. So if you're going to give anticoagulants, the first thing that we're going to ask you in clinicals, we're going to say, well, why are they on anticoagulants? What's the purpose behind it? So it could be because they have most common is AFib. It could be because they have a CVA. Okay. I have had a patient in the past who was actually on Xarelto. She had no history of AFib or CVA or anything, and we could not for the life of us figure out why on like Xarelto. Like it's not like it's not aspirin, okay? So we went and talked to the patient, talked to your patient. I said, why are you on it? And she said, and she had knee surgery. And she said, because I'm so at risk for clotting that they put me on the Xarelto just for a short amount of time because the Lovenox wasn't going to be enough for her and they didn't want her to clot. So talk to your patient. You're going to learn a lot of stuff from your patients. And one thing, if y'all don't know this yet, you are always learning in nursing. You will never know everything, ever. As instructors, we learn with you, okay? So, and when in doubt, I'm like, let's go talk to your patient because I'm not going to give them something that I don't understand why they're on it, okay? So just think about that. So these are just some examples, all right? So what are we going to assess for anticoagulants? Well, it's going to be the same thing again. I really want to be looking at their platelets, and I definitely want to look at their hemoglobin and hematocrit, and definitely with the hemoglobin more so. So if I'm starting to see that the trend is dropping and it's significantly dropping, I need to hold off on giving this just for right now and make a phone call if I have to, all right? Now, when I say significant, I will tell you this, guys. If I'm remembering my numbers correctly, I think the normal for women for hemoglobin is like 12 to 14. Don't hold me to that because I always get my numbers mixed up. And I think for men, it's 14 to 16. So if you come, I don't want you panicking and coming to me and saying, oh, Stacey, I'm supposed to give some Xarelto and their hemoglobin is 10. Oh my gosh, they need a blood transfusion. They're dying. No, they don't. All right. I'm going to tell you this right now. They do not give blood transfusions, majority of places, until they actually drop below 7. I know that's weird, but they don't, all right? So the reason is because we used to always give a blood transfusion with anybody that dropped below like 9 or 10, but too many patients were having reactions to the blood transfusions. So they really don't want to at all. What they're going to do is if they start to see that trend just go down a little bit at a time, they're going to order something like iron or some type of iron supplement like ferrous sulfate or something like that to see if the body can naturally start to bring it back up. Because if maybe they have a JP drain that's putting out some blood or a hemovac or something, or they lost a lot of blood in surgery. So they're really wanting the own body to reproduce those red blood cells. So don't panic. But if it is going down, I might have to say, oh, it in one day, again, it went from 10 to 8. That's a big drop, okay? So just make sure that you are looking at platelets for sure. So you'll have to say those numbers to us, as well as the hemoglobin and hematocrit. Now, that's for antiplatelets. That's for anticoagulants. But there's one of these that's a little bit different that we really need to be looking at, and that's the Coumadin, okay? You can look at platelets, you can look at hemoglobin, hematocrit all day long. That's fine. But the thing that we're wanting to know is what is their INR, okay? We don't care about their PT and PTT. I'm just going to tell you that right now. They look at INR. INR is saying, is it within a therapeutic range, okay? So the one thing I need you guys to know is I need y'all to know what is the normal INR, okay? Can anybody tell me what a normal INR is?
1 to 1.5.
Okay, so yeah, I think it's actually for a lot. It could be 1 to 1.5, but it's usually below 1 or like 1 and below. It kind of just depends. The thing that you're going to need to know is if your patient is on Coumadin and they're on it for AFib, for example, and every facility will have an INR chart, which basically says if they're on Coumadin for AFib, then their INR needs to be between 2 and 3. If they're on Coumadin, not for AFib, but because they have a mitral valve replacement, most places are going to say they want it between 2.5 and 3.5. So that's pretty dang high. Okay, so Barbara, hang on 1 second. Hang on. Let me finish with this and then ask. So that's a pretty high range. Okay, so when you look at that, don't forget and go, oh my gosh, they have their INR is 2.1. I'm like, okay, but why are they on it? Because they have AFib. I'm like, well then, okay, I'm not freaking out about it. But what I will say is that you better make sure that you're looking at the INRs when it comes to Coumadin. All right. Now, the higher the number, what does that mean? Does that mean that their blood is thinning or is it getting thicker? The higher the number, what?
Thinning. Slower clotting.
Yes, it's thinning. So that means that your patient is at risk for
Bleeding.
bleeding. Absolutely. Okay. So you've got to make sure that you're watching that. All right. So we're going to, again, go back to that aspirin while ago. I'm looking for bleeding in the gums. I'm looking for bleeding in the stool, in the urine, anything like that. All right. So I'm going to be watching for that because I don't know. I forgot my x-ray glasses. I can't see inside them. I have no idea where they're bleeding from. So that's what I have to make sure that I'm looking at. All right. So there
I apologize for interrupting. We can't see the board anymore. The camera has moved.
Oh, well, that's because Brian moved it a while ago. Okay, can y'all see that now?
Yeah, sorry for interrupting. That was what I was trying to say.
Okay, I'm sorry. That's fine. Okay, there you go, guys. Apologize for that. Well, he's taller. I'm not, so, you know, we can't always accommodate him. But anyways, okay, so just to make sure, guys, one more time, that yes, we've got anticoagulants. I want y'all still looking at the platelets, hemoglobin and hematocrit, especially for all three, that's fine. But Coumadin is different. Coumadin, you've got to look at the INR. Now, there's an antidote for only Coumadin. So if my patient comes in and their INR is 7.5, which is really high, there's only one thing that I can give them. Anybody know what it is?
Vitamin K.
It's vitamin K, okay? And I can only give it for Coumadin, okay? If somebody's on Eliquis or Xarelto and their INR comes back and it's 7.5, what do you think we're going to do?
Hold.
We're going to have that's all we can do, guys. That's it. We can only hold them. So the other thing is that you're like, well, why would somebody ever want to be on Xarelto or Eliquis? I would rather be on Coumadin knowing there's an antidote. Well, the problem is, and y'all know this, is that when it comes to Coumadin, you've got to go get those labs done. With Xarelto and Eliquis, you don't. So with patients, it's a convenience. It's their choice, guys. If they don't want to go in and go get those done, that's fine. We've taken care of patients before who had a hemorrhagic stroke, and they were on Xarelto, and there was nothing we could do. Okay? But if they were to come in and they had a stroke, then if there was something like they were on Coumadin, we could immediately go and give them vitamin K. So just know about those little things like that. Okay. Any other questions on the anticoagulants?
Pradaxa is included in that as well?
Yes, Pradaxa. There's a lot, guys. And Pradaxa is in the one with like Eliquis and Xarelto. There's a lot of them. Yes. But just remember that the Coumadin is the only thing that has an antidote, and is the only thing that we really want to look at that INR. We're not going to look at an INR for any of the other anticoagulants. We're not going to, because they don't look at therapeutic levels. Okay? All right. Let's move on to, okay, antibiotics. I'm just going to quickly go over, antibiotics are antibiotics, okay? You just need to know, if you're going to give vancomycin, if you're going to give Levaquin, Ancef, Cipro, whatever it is, you got to make sure that you're going to say, hey, I need to go give Levaquin, and it's PO, because y'all can do PO, and we're going to say, okay, well, why is your patient on it? Okay? That you can say, well, they came in with pneumonia, or they came in with a UTI, or whatever they came in with, or if we were going to acute care, it would be because maybe it's because they're on it for prophylactic. I don't know. What are you going to assess before you ever give any kind of antibiotic? It doesn't matter what kind of antibiotic it is. You're going to be able to look, you're going to look at white blood cells, and you're going to look at their temperature. Okay? Now, you need to make sure when you're looking at white blood cells, you need to make sure that you're going to look at the trend. Okay? Normals are anywhere between, some places it's 4 to 10, some places it's 5 to 11. It kind of depends on where you're at. So if my patient is on an antibiotic and I'm like, oh, okay, well, today their white blood cell count is 18. Okay, that's still pretty high. But yesterday or 2 days ago, it was 25. Am I concerned? No, because it's going down. But if I look at it and today it's 18 and 2 days ago it was 13, do I need to be concerned? Yes, because that either says the antibiotic is not working, or it says that they have another infection. It is not my job to decide that. That is the healthcare provider. My job is just to say, oops, I see that this is changing. I don't know if they want me to continue. I'm going to go ahead and call them, and then I'm going to let them know. It's not my job to do anything else but to notify them about that. Okay? So those are the two things for sure with any antibiotics. Okay? The one antibiotic that's a little bit weird that I really want to make sure that you guys know about, it's different, is vancomycin. Why is vancomycin different than all the antibiotics? Because vancomycin can definitely affect what on a patient?
Is this the trough?
No.
The
Yeah.
IV, it causes the extra.
Renal failure.
Yes, thank you, renal. Okay, so we need to be looking at Venco. Now, they could do what's called a Venco trough, or they can do something called a random Venco. Okay, a random Venco is just like, where is it at right now? A Venco trough means where is it at its lowest level. Now, if I'm going to start Brian on vancomycin today, okay, then I need to see that, oh, he's going to be on vancomycin, 1.5 grams every 24 hours. I'm just going to make it up. Okay, it's my job, though, as a nurse, when they first started, I need to, if they haven't already, I need to contact that healthcare provider, or usually pharmacy will pick it up, but I don't rely on anybody to do anybody else's job. And I need to say, hey, don't you want to have a Venco trough done? And it's always done before the second or third dose. Because what happens if he's on it every 24 hours, then if I'm the nurse and then I gave him, say, 2 doses of it, and now it's due at 11 o'clock today, what I'm going to do is go in there 30 minutes before. So I'm going to go in there at 10:30, and I'm going to draw a Vanco level, which is blood, and then I'm going to send it off. And then most places will say, go ahead and still hang the next dose anyways. But I need to, as a nurse, I better be checking what that Vanco level comes back at. Because if it comes back high when it should be at its lowest level, there's a problem. And I can't remember the exact numbers, but I think anything over 20 is high. I can't remember the exact numbers on that. So it's my job as a nurse to make sure that I'm watching that. One, they make sure that they've had a trough at some point. It comes back normal, then they don't usually do it again unless they start to see other things. But if I saw that, okay, he had a Vanco trough done 2 days ago, it was normal, but now I'm going to have to make sure I'm looking at his creatinine, because if that starts to spike, I might have to call the healthcare provider and say, I know he had a Vanco trough done 2 days ago. I know it was normal, but man, he is spiking on here. I don't know if the Vanco is causing his creatinine to spike or not. Not my job. My job is just to notice that there's any changes, assess, intervene when I can, and if I do intervene, then I have to evaluate, and if I can't do any of those because it's not within my scope of practice, I need to call the healthcare provider. Okay? So that's the thing with Vanco. You've got to look at renal. Now, the one thing is I'm like, oh, crud, I'm at a place that, I mean, we haven't even, we don't even have a lab done from so many days ago because we're at a rehab and they only do labs once a week. All right. And I'm like, well, a week ago his creatinine was fine, but gosh, I have no idea what it is today. There's some things that I can look at on a patient, okay, to see if there's something wrong. All right. So if my patient were to get into nephrotoxicity, what am I going to actually physically see on that patient? I'm going to actually see something that's going to be looking like, I'm going to look at their urine because that's renal, right? And it's going to be pink, cloudy urine. Okay? Now, if I notice that, and they have not had a Vanco trough like in over a week or a couple weeks or whatever, and I don't even have a most recent creatinine, then it's my job to notice this, okay, and then I'm just going to have to let somebody know because I don't know. Maybe maybe they just have an infection. I don't know, okay, but I can't ignore that because that could be a sign of nephrotoxicity. And all I need to do is call the doctor and say, hey, can I go ahead and get if they're still on the Vanco, can I go ahead and get a Vanco trough or a random Vanco? Also, can I go ahead and get some labs because I want to see what their BUN and creatinine is because I want to make sure that I'm not putting my patient into kidney failure. Okay, so that's the main thing with that. All right, any other questions on antibiotics or Vanco? Can I move on? Yes, I can move on. Okay, all right, so now I'm going to do steroids. Okay, that's the one I want to kind of go over with y'all really quick. So prednisone, that's the one we always look at. Well, we have to think about why is somebody on prednisone? Okay, well, usually they're on it for say COPD. That's just an example, especially like with asthma. Okay, so what is prednisone? Well, it's an anti-inflammatory, right? So hopefully with somebody with COPD, it's going to open up their airways so they can breathe better. Okay, so we got to make sure we go, well, why the heck are they even on it? All right, so some things to think about, especially with prednisone, is there some things you're going to have to watch for as a nurse. Okay. It can increase something and it can decrease something. Anybody know real quick, if you're on prednisone for a while, what can it increase? Anybody know?
Blood sugar.
Absolutely. Now that's usually more with diabetics, but it's not to say it can't happen with somebody else, but definitely diabetics, I am really watching that blood sugar. Okay, and I need to let my patient know, hey, they're freaking out because their blood sugars are all of a sudden spiking. And I'm like, I get it, but it's because you're on this prednisone. Once you get off of it, it should go back. What can it decrease on a patient?
White blood cells.
Okay, or immune system. Okay, so, or white blood cells, that's fine. So I'm sitting there thinking, all right, Mr. Brian, you're going to be on prednisone for, looks like, because you won't stop all smoking that you're doing or whatever he does, and then so they put him on it or something. So I'm going to tell him it's going to lower your immune system. Well, that's great, but he may not know what to do about that. I'm like, well, let me tell you something. I don't need you to be around large crowds. Okay, we're not supposed to be anyways at this time, but I don't want you to, because you never know if you're going to be around someone that's sick and your immune system's already down. If you were to start getting like a fever or a temperature, which is the same thing, you're kind of starting to feel run down, then or something like that, then you need to notify your healthcare provider, because you could start to be getting sick. Okay. Also with it, I think your book is talking about, especially with COVID and stuff, the vaccines are out there. If somebody's on prednisone, we're going to recommend that they don't really get any vaccines because their immune system's already low. All right. So that's something I want to make sure that you understand when it comes to like steroids with that. Now, something else with prednisone is you don't just stop it. All right. So they have to taper off, because that can actually mess up with their adrenal glands, and we don't want to do that. All right. So please make sure you say, look, when you get off, don't just stop taking it. You got to taper off of it. All right. If they're a diabetic, you say, watch your blood sugars. You may have to give yourself some extra insulin just for the time being. If their immune system could cause them to go down, you have to say, don't be around large crowds, call the doctor if you start feeling sick, things like that. All right. So I want to make sure that y'all are good. Now, does anybody know somebody who's on long-term prednisone, especially prednisone? Does anybody know what that could cause a problem with later on? Long-term.
Edema?
Nope, not edema.
Bone density?
You got it. Brittle bones. Woo, brittle bones. All right. So what that means is that puts them at risk for bone fracture. So when Brian's on this prednisone for the next so many years because, he can't breathe, well, then that gives me the opportunity to go push him down in the hallway and he's going to break his hip. All right. So don't be surprised that if you have a male patient, you're like, why am I giving them a calcium pill? Isn't that just for women with osteoporosis? Well, guess what? Long-term prednisone can actually cause brittle bones, okay, and osteoporosis with men, and so we're going to give them a calcium supplement, okay? So just to let you know, those are a couple things that I want with prednisone. Did I cover everything? I think I did. Is that it for that one? Huh? You mean glucose? Oh yeah, well I told it, yeah. So he was just asking me to make sure that I talked about that. If they're going to be on long-term prednisone, especially for diabetics, then yes, they're going to have to be on. They may have to increase their sugar. Now, here's the other thing I just want to tell you guys. I'm going to go back to something really quick. Sometimes patients are on prednisone or they're on other medications that can make their blood sugar spike, and they're not a diabetic. Okay, so you go in and you're going to say the patient's not diabetic, and then the tech comes to you and says, hey, Mr. Jones's blood sugar was 185, and so you're like, oh, I've got to go get some insulin. So you get with your instructor, you draw it all up, so you've got so many units of insulin, and then you go in and you say, hey, Mr. Jones, I'm here to give you 5 units of Novolog because your blood sugar was 185. And the patient looks at you and they say, why are you giving me insulin? And then you say, well, because your blood sugar was high. And then your patient turns to you and says, don't give me insulin because my cousin was in the hospital and they gave them insulin, and then that's how they became an insulin dependent. Do you see how people can think differently? They're thinking, oh, you gave them insulin and now they're dependent, and that's what they think the word insulin dependent means, when that's not it. Just like they think the same thing when you've heard about patients who can be on narcotics and then they get dependent on it, correct? So you've got to make sure that you can say, oh, no. That is not what happens at all, okay? Just because I have to give you some insulin will not make you a diabetic. It will not make you dependent. It's because of the fact that you're on prednisone or you're on some other medication and your blood sugar is high. Now, we really want to bring your blood sugar within a normal range because that promotes, does anybody know?
Healing?
Yes, healing, yay. So if you explain to your patient, they're like, oh, I get it. And I'm like, look, I'm sorry that we have to give you these injections. I know you don't like it, but hey, I don't want you here any longer than you absolutely have to. So let's do this, and then that's going to promote your healing. When we get your healing insulin taken care of, man, you're out of here. That's awesome. Okay, so there are some other medications that can increase the blood sugar that you might have to give some insulin to patients who are not diabetic, and a lot of them have the misconception of, if you give me insulin, now I'm dependent on it, just like my cousin was, and you're like, no, that's not how that works. Okay, so I just want to make sure that I go over that with you. Are y'all good? Okay, ready? We're gonna wrap it up on the medications. Man, if y'all don't pass this Pharm exam, I don't know what to tell you.
Yeah, at this point, right? All right, well, I'm very proud of you for making it this long. And I'm just going to wrap up the rest of the medications here by doing it quickly, efficiently, and easy to understand. But before I do that, Stacy said the long-term use of prednisone. What is the side effect? And someone said edema, and she said, okay, what's more important? And it was broken bones. But I want to say edema was a very good answer choice, because we know it causes moon face and buffalo hump on their back. And the thing is, that's very important, because your patient could say, I feel ugly. And we know in nursing that's called body image disturbance. So if you're a mental health nurse, that's very important. So that can, fractured bones will kill you quicker, but that was also a very good answer to consider as well. But in this instance, we want what will kill you. All right, moving on. The next classification of medications I'm going to talk about are your diuretics. Now, we're going to keep this very, very simple. There are conditions in the body where you have too much fluid and it's causing a host of problems. We have heart failure, where my body is filling with excessive fluids in the tissues and organs of the body. Also, the heart has to pump all that excess fluid, and that's causing extra resistance, causing hypertension. So we may be using diuretics for blood pressure control. We may be using diuretics for edema, with heart failure, what have you. But all I know is under diuretics, we'll begin with the thiazide diuretics. And your example of your thyroid diuretic is HCTZ for hydrochlorothiazide. It has thiazide right in that name, so you know what class that belongs to or what type of diuretic it is. And we know this HCTZ is for the treatment of hypertension. All diuretics cause me to diurese or void fluid, so of course that will get rid of that extra fluid, thus decreasing your blood pressure, okay? Another type of diuretic is your loop diuretic, and we know this is our most famous one. That is Lasix or furosemide, same thing, okay? And this one, because loop diuretics are the most powerful diuretics that we have in our diuretic arsenal, that this is going to be treating edema usually associated with heart failure, okay? So what I'm trying to tell you with this is, if the stem of your question is talking about heart failure and edema, please don't give me hydrochlorothiazide. Same thing, if it's talking about blood pressure, then it's hydrochlorothiazide, okay? So please, we do have a specific use for your diuretics. But I have good news. All of them are causing me to diurese, so your nursing care is universal for all diuretics. And you know, if I'm voiding or peeing like wildfire, that's what I'm diuresing, correct? I'm going to be losing fluid and electrolytes. And students say, oh, it's a fluid, so sodium, sodium, sodium. That's important, but that's not going to kill you the quickest. And you know, when it comes to level 2, someone's either dying or at risk for it in an emergency. So we need the electrolyte that will kill you the quickest. And you know, you always have to get a potassium level, because that's your cardiac electrolyte, when we're talking about diuretics because I will be excreting and excreting and excreting because it's causing me to diurese. Now, again, you already know ad nauseum 3.5 to 5 is your level. If it's lower than 3.5, what are you going to do? Stay off the phone, hold your diuretic, and then take it from there, okay? Now, other things is because they work directly on the kidneys, that's why it's causing me to diurese, is that we need to monitor input and output, okay? Especially output, because I need to know how much fluid is being lost and is the diuretic working. Another wonderful assessment of fluid status in the human body is you want a weight, and we'll monitor their weight. Hopefully, if their weight has increased due to fluid, once we give a diuretic and they pee it off, that their weight will decrease. The other thing is, because of kidneys, remember BUN and creatinine is your monitoring. We always love creatinine, best for renal function, okay? So again, your nursing care is standard for both of them. I need that potassium level, and students always say, oh, my patient is on a diuretic. Let's do foods high in potassium. And you say, eat a banana, eat a banana, eat a banana. Well, I can only eat so many bananas. You need to eat 20 of them to get your potassium up to a normal range, correct? So, of course, we reinforce a diet high in potassium. However, you may need to get an order for a potassium supplement when on a diuretic, okay? Now, my question to you is more nursing care we want to think of is these will, because I'm losing fluid, it will drop blood pressure. So again, be careful of orthostatic hypotension with changing positions. All right, now, my question to you today is, do you know why they call it LASIX? And I don't know if you've ever been taught this, but they call it LASIX because it lasts 6 hours, which means once I take that medication, I'm going to be diuresing or peeing for 6 hours. So my question to you as a prudent student nurse is, when would you want to administer this medication if they're going to be peeing for 6 hours? Do you want to do it in the morning, or do you want to do it in the evening? And you know, I don't want to give it in the evening because they'll be up for 6 hours peeing and trying to race to the bathroom, trip, fall, break a hip, and then the quella begins. So morning administration, because of that, 6 hours is best. But of course, if they're in complete heart failure and they have a catheter, it may be ordered several times throughout the day. Just know for someone in an outpatient at home or a maintenance dose, morning is best because of that 6 hours that it lasts, known as LASIX, okay? Now, there is a time when I check my potassium and the potassium is so low that I have to replace potassium, but the physician may choose to do a potassium sparing diuretic. And that is my third one on the list, correct? And I know that's known as aldactone and spironolactone. This diuretic is different than all the others because this one spares potassium, meaning you will hold on to it. So if I'm holding on to it, it doesn't matter because you check potassium for every electrolyte. We're looking for 3.5 to 5. But if I'm not getting rid of potassium with this diuretic, then what am I at risk for? You're not risk at low. Those were the other. You're at risk for hyperkalemia, known as greater than 5. Correct? So this is the one that's different. This is the one the students usually confuse their potassium levels with. So just be careful, it's opposite thinking, meaning aldactone is different than any other diuretic because it spares potassium, placing you at risk for hyperkalemia. Finally, you say, Brian, why don't we just everyone spironolactone, then we don't have to worry about the potassium ever going low. And it's because all diuretics are weak. Loop diuretics are the strongest, most powerful. So that's why you see the majority of your patients on a loop diuretic if they have to get rid of large amounts of fluid. Okay? That is diuretics. Potassium, potassium, potassium. All of them are hypokalemia with the exception of aldactone. You're at risk for hyper. All right, my final class I want to talk about, and even though it's one of the more simpler classes, it confuses a lot of students. So I really need you to listen to my language and my words that I use. And it's the upper GI medications, okay? First of all, I want you to remember for our GI medications, there's a trick to this. Some of my GI medications, all of them are dealing with hydrochloric acid, correct? Which causes peptic ulcer disease and or heartburn is what we're concerned about. But how is it working to control GERD or heartburn? So the very first one, they either neutralize, they reduce acid, or they stop, block, or inhibit. Those are your three choices. So when I tell you I have GERD or heartburn from hydrochloric acid, if I want to neutralize it, I need to eat something, correct? And what I'm consuming at that time to neutralize will be your products such as Tums. And we know Tums are your calcium carbonate products. They neutralize. Now, for the reduction of hydrochloric acid in the GI tract, we can give a medication that works directly on the secretory cell or the parietal cell that releases hydrochloric acid, and we can reduce its production of. And the one on your list is famotidine or Pepsid. Okay? This one reduces. Now, I don't know if you've ever gone to your neighborhood drugstore, but I would say 5 years or more now that they are behind a locked case, and you have to have them unlock it to give you this. Why is that? Because this is directly acting or reducing the production via your cells, or the parietal cell in the GI tract. Anything that works long time farting around with a cell, you're at risk for mutation and or development of cancer, correct? Because it's working directly on the cell. So that is why they're trying to keep track, because you do not want to be on Pepsid or famotidine more than 2 weeks. So 2 weeks usually is the limit for an acid reducer. I don't know if you watch TV, but there's a commercial about one of these, I think it was Tagamet, and it's a class action lawsuit. Come join our lawsuit because it was linked to gastric cancer. So all I'm saying is it's short-term use, used to reduce, it works directly on the cell. Finally, there is a class of medication that stops, blocks, or inhibits, which means the acid will not be produced at all. And to remember that, we're going to inhibit or stop, and that's right in your medication known as proton pump inhibitor. It stops that proton pump from releasing hydrochloric acid. And we know the proton pump inhibitor, Protonix, is right. The word proton is right in it, okay? So just to recap quickly, I need you to pay attention to the stem of your question. If it says Mary Jo Botafuco has GERD and you want to reduce her hydrochloric acid, reduction is our Pepcid famotidine. If you are inhibiting or blocking, the physician is proton pump inhibitor. It's right in the word, okay? What about neutralize? Then we turn to our Tums and over-the-counter medication. So those are your code words. Neutralize, reduce, stop. Done. Okay. Does anyone have any questions? I know someone rang in and I just kept on talking through. Hello? Is anyone still here? Okay, so that is the end of medications. Now, of course, we can't go over all of them for the sake of time, but we did the most critical, important classes, so please just use the acronym NURSE to study the others quickly that I explained earlier. All right, now how long are we breaking?